The following podcast is part of a certified educational activity titled A Better Blend for Follicular Lymphoma: How Targeted Therapy, Epigenetic, and Immune Therapies Are Changing Patient Care. Access the entire activity and complete the post-test at peerview.com/FJR860. Downloadable slides and practice aids are also available.
Hello, and welcome to A Better Blend for Follicular Lymphoma: How Targeted, Epigenetic, and Immune Therapies Are Changing Patient Care. I'm Dr. Nathan Bartlett from the Anderson Cancer Center in Houston, and I'm really happy today to be joined by some very established and esteemed colleagues, Dr. Krish Patel at Swedish Cancer Institute in Seattle, and Dr. Nancy Bartlett from WashU in St. Louis. So let's start out. I'm going to just give us a quick introduction and talk about a case that we can kind of use as we go through the activity. So a little bit of background in follicular lymphoma. The disease has a long natural history in the vast majority of patients. However, response duration and many times survival do shorten after each relapse. This is data from more recent era, specifically the rituximab era. And you can see that both response duration and overall survival in broad cohorts of patients does unfortunately tend to get worse with each line of therapy. And the colors of each of these little lines represents treatment. So we have a lot of new drugs that are approved. These are some recent approvals of novel therapies specifically for relapsed follicular lymphoma. We'll talk about a lot of these. We have IMiD combinations, which have recently been approved, lenalidomide, rituximab. There are several PI3 kinase inhibitors, which we'll touch on, epigenetic modifiers like Tasmetostat. And just this year, we saw the approval of the first CAR T cell in follicular lymphoma. Now, the NCCN recommends several different options for patients in their second line or greater. Bendamustine plus obinutuzumab or rituximab, R-CHOP or obinutuzumab CHOP, rituximab plus CBP, obinutuzumab CBP, or lenalidomide and rituximab. And we'll talk about these. There are some other recommended options for second line, and that includes ipilimumab, lenalidomide, obin, rituximab, and obinutuzumab as single agent. So a lot of options for these patients, thank goodness, in the second line and greater. Now, there are lots of options for sequential therapy for third line and beyond. PI3 kinase inhibitors are recommended. As I mentioned, there are 4 of these that are currently approved, and we'll discuss these in this activity. Tasmetostat and CAR T cell. So let's start with a case. So Kevin is a 66-year-old man. He has stage 4 follicular lymphoma, which is very common when this disease presents. He's in very good health. His ECOG performance status is 0. On immunohistochemistry, we did a biopsy in the immunohistochemistry showed the cells in his biopsy were positive CD10, CD20, and BCL2. All of these classic markers for follicular lymphoma. He had symptomatic disease, and so he was started on therapy. He got bendamustine rituximab, did very well throughout the treatment, but unfortunately had a relapse within 2 years of starting bendamustine and rituximab. Now, in all patients that relapse, especially patients who relapse early, I think it's critical that we get a biopsy to rule out any aggressive transformation. And that's what we did. And in this patient, there was no evidence of transformation into a more aggressive disease like diffuse large B-cell. He was then started on lenalidomide and rituximab. He received aspirin as a thromboprophylaxis prior to starting R-squared. And he responded great, although he did have some neutropenia that was seen in his third course of R-squared. He received growth factor support and remains in remission after 1 year of finishing treatment. So we'll come back to this case and we'll kind of think about options that would be available for him throughout the course in the second and third line and fourth line and beyond. So again, we're going to focus on the role of PI3 kinase inhibitors for patient management. We'll also look at this really new and emerging data around EZH2 therapies. And finally, we'll talk about these really new and exciting drugs such as cellular therapy options for patients with local disease. So I'll start us out, and I'm going to talk about drugs which have really been evolving. We've seen several new drugs now in this class which have been approved, and that's PI3 kinase inhibitors. So let's come back to the case. Again, Kevin is, as I mentioned, he's a 66-year-old man when he was diagnosed. So he's a couple years older now. And he had bendamustine rituximab, had R squared. But now it's 16 months later, and he has some symptoms suggesting that he's relapsing. He had imaging studies which confirmed that he had neuroadenopathy at multiple sites, both above and below the diaphragm. So what should we do? And if we're considering a PI3 kinase inhibitor, what would be the best option, and how would we dose him? So I'll use that as a kind of an introduction to talk about this class of drugs. PI3 kinase inhibitors hit multiple targets. We know that follicular lymphoma is a disease where there's a lot of genetic redundancy. There are often many different signaling pathways that are turned on and unfortunately can lead to pro-survival in these malignant clones. The good news is that PI3 kinase hits multiple signaling pathways. You can see from this kind of complex slide that PI3 kinase is important for signaling downstream from the B-cell receptor, from several cytokine receptors, such as CXCR5 and CD40, as well as downstream from integrin. And the activation through these pathways, unfortunately, can give these malignant clones both a survival advantage as well as increased proliferation rate, and potentially changes the microenvironment that's present within the tumor. So it makes sense to block, some of these pathways that are giving these malignant clones an edge. Now, there are 4 of these drugs that are currently FDA approved. These are the structures. Again, I'm not a chemist, but when I look at these, they all look somewhat similar. There are some small changes. They all hit different isoforms of PI3 kinase at a little bit different efficacy levels. The main one that I think all of these tend to target, and probably the one that's most relevant for hematologic malignancies, is the delta isoform of PI3 kinase. Now, the first one of these drugs that was FDA approved was idelalisib, and it was approved from a very simple, I should say simple meaning simple design, phase 2 trial. This trial looked at patients that had relapsed and refractory follicular lymphoma. All these patients had prior Rituxan and bendamustine. And you can see with this drug given as a single agent in these patients with relapsed follicular marginal zone NSLL, that most patients responded. And this waterfall plot, everything below the line shows that the tumors are shrinking. And again, the point of this is that the vast majority of people, regardless of the type of indolent lymphoma, had some shrinkage in their tumor. Now, since this study was published, there have been several subsequent next-generation PI3 kinase inhibitors which were approved, including duvelisib, copanlisib, and most recently, umbralisib. Now, the Dynamo study is the study that got duvelisib approved. Again, it was a very similar design. It was a phase 2 single-arm study, about the same number of patients, 129 patients, all with double refractory indolent lymphomas. And you can see this waterfall plot actually looks very, very similar to the prior slide. Most patients having some response. The overall response rate was 47%, which is also very similar to what we had seen with idelalisib. Median progression-free survival of 9.5 months. Copanlisib is an IV formulation of a PI3 kinase inhibitor. It hits a slightly different isoform. then dualism or idealism. And again, these waterfall plots, I like to kind of joke you could overlay these all kind of on top of each other. All looks very, very similar. Overall response rate here, 60%. Duration of response, 14 months. And the progression-free survival here, also very, very similar at 11 months. So copanalism was also looked at more recently in a or I should say a double-arm study. This study looked at, this is called the Kronos-3 study. Primary endpoint was progression-free survival. They enrolled patients with indolent lymphoma who had relapsed after at least one prior therapy. And this was a pretty simple design. They looked at copanalisib plus rituximab versus rituximab alone. And these are your progression-free survival curves. There was a clear benefit of adding copanalisib to a rituximab backbone. Again, the experimental arm had rituximab alone or rituximab plus placebo. These are the safety results. I think the adverse events that we generally think about when we use copanalisib are hyperglycemia and hypertension. They were obviously more often seen in the arm that had copanalisib. You can see 56%. This is all grade hyperglycemia compared to 8% with rituximab placebo, 40% hypertension compared to 9% in the single agent rituximab arm. Dose interruptions did occur, although they were fairly uncommon. Due to hyperglycemia, you can see it occurred around less than 10% of patients in the arm that had copanalisib plus rituximab. Most of these events were managed very effectively with just using some type of glucose-lowering agents, such as insulin, oral anti-hyperglycemia indications. The same thing with antihypertensive therapy. Very few patients had to stop drug, as I mentioned, and most of these adverse events were very short-lived. Now, the side effects that we generally think about in this class include diarrhea and colitis. And the good news is with this drug, there was an extremely low incidence of diarrhea or significant colitis. That means grade 3 or greater. Now, moving on, as I mentioned, we most recently saw another oral drug that was approved for relapse follicular, and that's umbralisib. This was just published this year in JCO, and that study that got this drug approved was called the Unity NHL trial. Again, I don't mean to sound like a broken record, but again, very simple design here. This was a single-arm phase 2 trial, again looking at patients with relapsed and refractory low-grade lymphomas, marginal zone, follicular, and SLL. As we saw in the other studies, the drug was given as a single agent with a primary endpoint of overall response. This is the waterfall plot. Again, compared to the last three I showed, it looks very, very similar. The vast majority of patients having some shrinkage or reduction in tumor volume. Overall response rate in follicular lymphoma, 45%, and right around 50% in both marginal zone and in SLL. Based upon this study, the FDA just approved this year umbralisib for treatment of patients with relapsed and follicular lymphoma in their third line or greater. This is the duration of response, quite long in majority of patients, again, all right around a year. And progression-free survival, also very similar to what we had seen in the other three drugs. Actually, I always like to comment, it's shocking how similar the progression-free survival is across all of the drugs in this class, all of them right around 10 to 11 months, regardless of the agent. We also saw clear benefit in patients with relapsed SLL and marginal zone. Now, adverse events, again, I think are obviously very important when we're looking across these class of drugs. They all differ slightly. There was diarrhea and a little, very, very low incidence of colitis with this drug, as we've seen with the other oral PI3 kinase inhibitors, although the grade 3 events were low at only 10%. We also saw a smattering of other adverse events, although if you look at the column here that says grade 3, they were really uncommon. We had a little bit of nausea, fatigue, headache, etc., but these were generally occurring in single digits. So we now have another oral PI3 kinase inhibitor. This drug is not yet FDA approved. This is zandelisib. This drug has a very long half-life, and there are current studies that are ongoing, and many of those that are currently being presented, where we look at the use of this drug using a very different or a slightly different schedule. This is intermittent dosing, and the idea behind this intermittent dosing is that potentially we could decrease some of the adverse events that have been seen in some of the other prior drugs. As I mentioned, it's currently being assessed in several ongoing trials. The title study looked at this in follicular lymphoma, very similar to the other studies who had received at least 2 prior lines of therapy. And I'm happy to say in that study, we saw a very active response rate, 70% overall response rate with a 35% CR rate. So just last year, Andy Zelenitz presented the early results of phase 1b trial using zandelisib. And we saw very nice, as I mentioned, overall response rates, and it was fairly well tolerated. As I mentioned, the study was a phase 2 study looking at this drug as a single agent. As I mentioned, it has a very interesting schedule, and in this trial, they used 60 milligrams daily for 8 weeks, but then switched to an intermittent dosing schedule on days 1 through 7 of each basically monthly cycle as monotherapy or combined with rituximab for up to 8 doses. PJP prophylaxis was used at all patients. And looking here at the, again, response rate, you can see the overall response rate, it was very, very high, 83%, and 22% overall. But I think more importantly, we saw very nice responses in both arms, both in the monotherapy as well as the PI3 kinase plus rituximab arm. We saw a update by John Pagel at ASCO this year, and this was now looking at high-risk patients, patients that had progressed within 2 years of initial therapy. And here the overall response rate also looked very, very high, but it looked high both in patients that had POD24 as well as patients who had later relapse. Now, the numbers here are very small, but again, exciting that it appears to work even in this population where traditionally they tend to have more inferior outcomes. Now, this is the duration of response curve. And again, it looks pretty similar, very active, both as monotherapy, as well as in patients who receive the drug with rituximab. Median duration of response has not yet been reached in either arm, and has not been reached in patients who were in the POD24 group. Looking at adverse events, it was very well tolerated. I want to just highlight here that the incidence of diarrhea occurred in only 2 patients. That's around 5%. Both of those patients had some colitis, but it was very, again, say very, very low compared to many of the drugs in this class. There didn't appear to be any difference in the incidence of adverse events, again, small numbers, in patients who were in the POD24 group and those who had progressed later. There was only one case of pneumonitis, and that was only grade 2. A very low rate of discontinuation, only 8% of patients had to discontinue drug due to an adverse event. So I think that the jury is still out there, but it appears that at least either the drug or this intermittent dosing schedule is associated with very well tolerance and a low rate of stopping drug due to potential toxicity. And that type of schedule is also associated with high rates of disease control in this relapse population, including high-risk disease. So I wanted to put together just a quick slide kind of summarizing all of these drugs, because 4 of these are currently available in the clinic. And I think now that we have all of these available, one of the questions that I often get is, how do we choose? And unfortunately, there's no really easy answer. As I mentioned, it's very surprising how similar the efficacy is across all four of these drugs that are currently FDA approved. If you look at the overall response rates, they're all right around 50 to 60%, progression-free survival all around 10 to 11 months, regardless of the agent. And now, I think the differentiator there is often toxicity profiles. So, again, as we always talk about, you have to individualize treatment when you're thinking about follicular lymphoma. The rate of diarrhea and colitis does appear to be the lowest in the IV formulation of a PI3 kinase inhibitor, that's copanlisib, although that's offset with increased rates of hyperglycemia and hypertension. All of the drugs are associated with a increased risk of pneumonitis as well as opportunistic infections. So I think regardless of the drug, we always have to kind of watch closely for that, especially in this era where patients are unfortunately at risk for other type of pulmonary complications due to COVID. So let's come back to our case. Kevin, as I mentioned, had received bendamustine. He then went on to receive R squared around 16 months later. He has now progressed, and PI3 kinase inhibitors, I think, are a reasonable option. So I'm actually going to pivot a little bit and maybe ask Nancy or Krish, what would you think about so let's say you're considering a PI3 kinase inhibitor, how do you choose? Have you had a case like this where you've had multiple options, and what made you pick one versus the other? Nancy, how about a
Yeah, so I that was great, and I think it's very hard to choose. And I guess I haven't given the copanlisib yet because of the IV formulation and the schedule. We see a lot of patients who come from a distance, and it's just makes it a bit overwhelming for them. So then I'm sort of have chosen duvelisib most commonly. I think just because that was the next one available and seemed to have a better toxicity profile than the initial idelalisib studies, but I don't think that's been tried head to head, so a little hard to know. I haven't yet used umbralisib. I think your data with the next one in line that's not yet approved looks really interesting, and seems like maybe the response rates are a bit better than the other four, where they all look so similar. Be good to see some longer term follow up with that. So, and I think, I mean, there's not a particular patient where I would, completely avoid this. So I'm, again, right now I choose duvelisib, but I certainly might go with one of the umbralisib, if that, or the new one when that's approved.
And how about Krish? What do you think? I mean, have you used many PI3 kinase inhibitors for this population of, let's say, third line follicular?
Yeah, so I think much like Nancy pointed out, here in Seattle, we see patients from all over the place, including Alaska and Hawaii at times. And so mostly my experience has been with the oral agents. We also have the zandalisib trial here, so we've treated a number of patients. As you mentioned, John presented data at ASCO. And so my experience is much like Nancy's, which the toxicity profile really probably drives my choice of agents, and I've found at least duvelisib and umbralisib seem to be well tolerated, and those are usually my go-to options if the patient's not going on a study.
Yeah, yeah. I have to say, it's interesting, I think it's my opinion that when we had Idella, we had all these. It seems like we had all these. I say all. There were just a small subset of patients who, at least in my own practice, had really bad diarrhea and colitis, and I think that maybe because we didn't know how to manage the drugs, or maybe it was the class. But I think a lot of people avoided PI3 kinase inhibitors at all costs. It was one of these agents that you used as kind of a last resort. And now, at least in my own opinion, I think as we get these newer oral agents, it appears that at least the discontinuation rate and the incidence of really severe events is going down. But Nancy, you pointed out, it's hard to know whether is this that we're getting better at managing these drugs, or is it actually a difference in I think that probably is, in my opinion, it's probably a little both. Yeah, I think we're getting better at it. I think the drugs probably are a little bit better tolerated, but um, yeah, in my own practice, I tend to go with the newer PI3s. Again, I've had a lot of experience with umbralisib, so it's kind of my go-to now that I can get it through the outside of a clinical trial. But um, and I really echo your thoughts about the IV. Um, at least for folks like, and then both you guys are in referral centers. So all my patients are traveling. It's hard to get them back to do IV because they just don't want to travel.
Right. So probably better choice out there in the community, perhaps, when the patient lives close by and can do that. Yeah, I think that as you're saying, just the experience with these drugs and knowing that we need to give PJP prophylaxis and occasionally monitor for CMV and those things make us a little less nervous about using the drugs than when all of the everything came out about the late infections with idelalisib and I think we've all learned from that. I think we've all learned from the LFT abnormalities that we saw very frequently in the idelalisib patients early on, but you can sort of take a short pause and start again without a problem. And I'm not sure if that's true of the other agents or you've had experience with that.
Yeah, no, I agree. If with one thing I've noted, and I didn't really focus on that when I presented this, but most patients, at least in the umbralisib study, were able to restart drug. As you mentioned, you can get a break, and most of them, um, many times even without dose reduction, were able to restart and manage without a lot of diarrhea. At least in my own practice, if they have a grade 3 event, I tend to reduce the dose. So that's well tolerated. There are some people that they get it again and they get diarrhea and we just stop. But that's a long answer to your short question. But I have restarted and most people will tolerate it. Um, just because of the I guess what we're seeing now. What do you think about COVID? I mean, are you concerned about? I mean, not concerned about COVID, but with the pneumonitis, is this a drug class that you monitor more closely?
I think you raised an important point, Nathan, which is in all of these agents, right, there's a significant rate of opportunistic infection. So I think I certainly talk to patients and counsel them, and I haven't necessarily seen a different rate of COVID in patients treated with PI3 kinase inhibitors relative to really any other therapies that knock down B cells for follicular lymphoma, but it is a concern. I did want to make a comment on, one of the things I think is really interesting about the zandalisib data is that you can maintain those rates of response with such little time on drug after that initial 8-week period. So that I think really kind of highlights to maybe a difference in potency of that therapy. And perhaps that'll offer us benefits in terms of lesser rates of infection in the long term or other immune-mediated toxicity. So I think that's one to watch.
Yeah, I'm excited to see the long-term data. Maybe you'll be presenting this soon. We'll see. So again, we kind of talked about this a little bit. I think we've heard very clearly that the kind of things that we think about when we're choosing between these drugs is the delivery of the drug, IV versus oral, AE profiles, colitis versus hypoglycemia, hypertension, and we talked a little bit about infection risk, and we didn't mention much about prophylaxis. But I think that at least in my own practice, I monitor these patients for CMV, and in patients who are high risk, we sometimes do prophylaxis. I don't know if Nancy, if that's kind of the same that you guys are doing at WashU.
We do PJP prophylaxis, but I don't give any other antibiotics. Yeah.
Yeah. Good. I think that's probably pretty. I noticed when there was when I think it was idelalisib, there was when some of this came out in the label, there was a suggestion to monitor these patients for CMV. Um, I know at least in my own practice, I tend to wait until unless there's some reason to check CMV levels, but I don't routinely monitor CMV unless it's a high risk population. I don't know if that's kind of the same way you guys.
Yeah, I think unless somebody has some concern for a site of infection like colitis or something like that, we don't usually check.
Okay. So Thank you very much, and I am going to switch to Krish Patel, who's going to talk about some exciting epigenetic approaches.
Thank you, Nathan, and thanks for the great talk on PI3 kinase inhibitors. So now I'm going to switch gears a little bit and talk about epigenetic modifying therapies in follicular lymphoma. So coming back to our case of Kevin, this patient, as Nathan highlighted for us, about 16 months after treatment with lenalidomide and rituximab, is experiencing disease progression. And so what might we consider as an alternative to PI3 kinase inhibitors? And I'll review some of the data for EZH2 inhibitors, specifically tasmetostat in this patient, and then come back to consider why that might be a choice for a patient like this. So just again, noting that tasmetostat is reflected in the NCCN guidelines for patients with follicular lymphoma. And importantly, this can be used in patients who are either mutation positive for EZH2 gain of function mutation or who have EZH2 wild type status. There are a number of different EZH2 inhibitors that are in development, not only for non-Hodgkin's lymphomas, but other malignancies as well. Those are noted here. And tasmetostat is the only currently approved agent for follicular lymphoma. So why is this important? So tasmetostat's an oral inhibitor of EZH2, and EZH2 is a histone methyltransferase. It plays an important role in epigenetic regulation of gene expression. And this is really important in normal B-cell biology. And so shown in the cartoon on the right, as a B-cell matures in the germinal center, either EZH2 is increased in expression and locks the B-cell in the germinal center state as a part of its normal maturation. And in this particular step, we can see that either oncogenic mutations in EZH2, so gain of function mutations, or increased copy numbers can permanently lock the B-cell in this state, leading to germinal center-derived neoplasms. And we see in about 20 to 25% of patients with follicular lymphoma will have a gain of function mutation in EZH2. Wild type is important here as well because, as I mentioned, there can be other ways that EZH2 expression is increased either through gain of function, increased copy numbers rather than gain of function alone. So we can target EZH2 in follicular lymphoma, and this was the focus of the phase 2 study that led to the approval of tasmetostat in relapse refractory follicular lymphoma. These data were first presented at ASH in 2019 and then published in Lancet Oncology in 2020. And this was also a relatively straightforward phase 2 open label study, a multi-center study done globally. And what we see here is that really we had two cohorts of patients enrolled, those who had a gain of function mutation in EZH2 or those patients who were wild type. All patients in the study had had at least one prior line of therapy and then were treated with tasmetostat at a dose of 800 milligrams twice daily until disease progression or intolerance. Response assessment in this study was done with the 2007 IWG criteria, and we'll show those data shortly. So who are the patients in this study? Here you see, again, what we would typically expect for a trial in follicular lymphoma, median age in the 60s, and most patients had excellent performance status as noted here. Most patients in the study were treated with 2 lines or more of therapy, so median of 2 lines of prior therapy. And the wild type patients, median lines of therapy were 3. And you'll see even as many as 15 to 30% of the patients, depending on the cohort, with more than 5 lines of prior therapy. So these were relatively heavily pretreated patients. Thinking about some of our high-risk populations, so there were patients who had transformed follicular lymphoma or grade 3B follicular lymphoma in this trial. So I think that's unique in comparison to other agents where typically patients with grade 3B or transformed disease are excluded. And we note that about half of the patients in each cohort were refractory to a rituximab-containing regimen, and about similar number to the last regimen used. And then if we think about the patients, as Nathan pointed out earlier, as patients go on through subsequent therapies, the progression-free survival and overall survival decrease. And so noting here that the median time from initial diagnosis in these patients was relatively long. So this is the waterfall plot for the cohort of patients with gain-of-function EZH2 mutation. And what we note here is that 98% of the patients had some evidence of tumor reduction, as shown here. And then looking at patients with wild-type EZH2, what we note is about 65% of the patients in the cohort had a reduction in tumor volume. Interestingly, this kind of difference in radiographic measurement of disease response didn't seem to translate into a difference in progression-free survival. Again, when we look at progression-free survival in the two different cohorts, it's relatively similar. So median PFS was just shy of 14 months in the EZH2 mutated cohort and 11 months in the EZH2 wild-type cohort. And I think this is interesting because it suggests that perhaps there is, something more important than the tumor shrinkage alone that may drive clinical benefit in patients with this therapy. I think most excitingly with Tasmetostat is it is really a therapy that has a very low toxicity profile. So if we look at all grade toxicity, so really even grade 1 and grade 2 toxicities, the most common toxicity was nausea in 23%, so relatively low rates of even grade 1 and grade 2 toxicity. And if we look at grade 3 or 4 toxicity, that was extremely low, with cytopenias, thrombocytopenia or anemia being the more common, but those being in single digit incidences. So the majority of patients in this study tolerated the Tasmetostat extremely well, with very few patients requiring discontinuation. There were about a quarter of patients that had dose interruptions due to treatment emergent adverse events, as noted. So when we think about what we learned from this trial, I think importantly it shows that Tasmetostat has meaningful clinical activity and the potential for durable responses in patients, especially those that are relatively heavily pretreated. And I think importantly, a very low rate of high-grade toxicities, which suggests that this is going to be an agent that really can be combined with other therapies and be a good partner for other therapies that we already recognize are active in follicular lymphoma. And that's the focus of two ongoing trials, one with Tasmetostat plus lenalidomide and rituximab, and another with rituximab alone. So I'll just briefly review those study schemas. So there is an ongoing phase 1b/3 study of Tasmetostat plus lenalidomide and rituximab in the second-line setting, compared to the combination of just lenalidomide and rituximab as a standard of care control arm. Importantly, this study started with a safety run-in, and the results of that phase 1b safety run-in will be presented this year by Connie Bartlett from Memorial Sloan Kettering. And just highlighting from the abstract, of the 12 patients in that run-in who were evaluable for tumor assessments, just about 40% of the patients had complete responses with an overall response rate of 91.7%. So I think an important study that we'll all watch in the coming years to try to understand what this combination might offer patients. Another study ongoing, this study is called Symphony 2. This study started as an investigator-initiated study at our center that has now become a multi-center study, looks at the combination of Tasmetostat with rituximab in patients who have had at least 2 prior lines of therapy, and we'll be presenting a trials in progress poster for that on Monday evening. And you see the study design here. This study design actually uses a fixed duration of treatment, so 24 total cycles of Tasmetostat with 6 cycles of rituximab, as shown here. And the overall response rate actually in the wild type patients is the primary objective of the study. So just thinking about Tasmetostat and where this fits, or EZH2 inhibition in general, I think, we recognize that the field is moving towards chemotherapy-free options in the management of relapse refractory follicular lymphoma, and the activity as a single agent of Tasmetostat, both in patients with gain-of-function mutation or wild type, as well as its very favorable toxicity profile, I think makes it an exciting agent to combine with other therapies that are active in this space. So if we come back to our case of Kevin, thinking about Tasmetostat, he certainly is a patient that looks like those treated in the phase 2 trial, a patient who had had a short remission to initial bendamustine and rituximab, has received lenalidomide and rituximab as well. And when I think about Tasmetostat in my patients in the clinic, I often think about those patients who maybe the avoidance of certain toxicities is going to be important. So as Nathan highlighted, for example, immune-mediated toxicities can be an issue with PI3 kinase inhibitors. Those also can be an issue with immunotherapies, as Dr. Bartlett is going to discuss later. So as an example, patients that might have autoimmune conditions, this is a really important low therapy or low toxicity therapy that might be important. But I would say broadly can really be considered in any patient type, given the single agent activity and the safety profile. And then just some additional considerations when using Tasmetostat. So I think initially when this agent was approved, there was some, I think, confusion is fair to say about the label indication. So I think it's important to recognize we can use this agent in patients regardless of their EZH2 mutation status. So it's not necessary for testing. However, I do think that testing is helpful in thinking about how to assess responses. So recognizing that there is this difference in depth of response as seen in the phase 2 study, that can be helpful if we're trying to understand, okay, what are we looking for in these objective responses that we're looking for radiographically. So we can use it in any patient. Typically in our institution, we do EZH2 testing now at diagnosis. This is a mutation that's usually, if present, going to be present at diagnosis. It's not a mutation that is acquired later in the disease course. And importantly, we want to know that responses can take some time with this agent. So the median time to response in the phase 2 trial is about 3.7 months. And so if patients are clinically benefiting, their symptoms that may be due to follicular lymphoma are improving, perhaps their blood counts, if they had cytopenias, are improving, I think it's important to try to keep the patients on these agents. And we can see that depth of response evolves over time. And so I think clinical benefit is really important to assess in patients when we're using Tasmetostat. And another note, just to note, we do want to be mindful of secondary malignancies. So there have been a small number of secondary malignancies reported in patients treated with Tasmetostat, including MDS and AML. Again, that's a low frequency, but really something to be aware of, especially as we're monitoring patients' blood counts. So I'd like to ask Nathan and Nancy kind of what your thoughts are about Tasmetostat and how you're using this agent in your clinic to treat patients with relapsed refractory follicular lymphoma.
I'll start. And that was a really helpful review of the drug. And I think you really highlighted what I see as the big advantage of this drug, which is the lack of toxicity. So in the patients that I've treated, I cannot remember seeing any toxicity in the patients, which they really appreciate after having been through several lines of prior therapy. And so I see it as a drug that even though the response rates and the CR rates are not, exceedingly high, that because there's no toxicity, if your patient is still not in some sort of extremis from their follicular lymphoma, that I think it is something that we had the advantage with this disease over more aggressive lymphomas, that they can, try this first. And if they respond, then, potentially another really, advantage over waiting for more toxic therapies.
I agree with Nancy. Yeah, the side effect profile of this drug is really phenomenal. I have, I can think of, again, my own patients. I think I have 3 patients on this drug now. And at least, again, small number, but my other thing that I've noted is it takes a long time for, in fact, I can tell you the first patient, I was fooled a little bit because I didn't see any response in the first 3 months. And then I kept them on drug. And this patient has now been on drug about a year. And each time I see him, it shrinks another 10%, 15%. And, what I often tell patients, because we look at the scans together and we kind of debate whether, okay, if we keep going or should we stop? And for me, that conversation is always it's always kind of a risk benefit ratio. So in a disease, in a drug that doesn't have a lot of side effects, I usually tell them, hey, you know what? It's not, nothing's growing, probably some benefit, and let's stay on drug. And that's, again, it's very different than a drug where, for example, they had pneumonitis, and there you're only getting a 5% reduction in the tumor. There, I'm more likely to stop. But again, because of the side effect profile, I think it really is kind of neat that a lot of these patients, I just keep them on, and I just see this little bit of reduction each time I get an image. Um, so, but what patient population? It kind of goes back to in a population where I think if you've got something that's rapidly progressing, that you need to really debulk, I might not go here first. I do think some of the other agents probably have a more, um, the profile is more suggestive of a more rapid response at first restaging. Um, and then the other thing I like to always kind of think about in follicular is that it's not just the line of therapy, but it's the time between lines. So, in a patient who is rapidly progressing between therapies, then I'm really thinking that, they would benefit from, actually, Nancy's going to go there, a more like maybe definitive type approach, like a transplant or cell therapy. So I guess what I'm trying to get is in the patient who has gone long time between therapies, maybe has medium volume, it's a great option because we have the luxury of kind of just watching and seeing how they do. So, and that's the population of the 332 patients that I have. They kind of been watching them. They kind of slowly started to get more volume, and then we made a kind of decision together to start this drug, and all three of them are responding. So, so I will. Anything else, Krish? I think that we didn't touch on.
No, thank you. You guys highlighted it well. Thanks.
Then why don't we move on and talk about, again, I think a really exciting new class of drugs, and one of those was just approved this year, and that's these kind of new cellular therapy approaches. And I'll turn it over to Nancy Bartlett, who has led a lot of the charge in using these kind of drugs in the clinic. Dr. Bartlett.
Great. Thank you so much. It's really my pleasure to participate in this symposium today. And so I'm going to take a little bit of a turn here and look at immunotherapy, specifically CAR T cell therapy and bispecific antibodies in patients with relapsed and refractory follicular lymphoma. So just again, to revisit this case, which we've been talking about through the session, the 66-year-old gentleman who has now relapsed twice after BR and R squared. And so the question is, are there immunotherapy options for this patient? So just going to revisit the NCCN guidelines again, which we've again already seen, and highlight the fact that the anti-CD19 CAR T cell therapy Axicell was approved earlier this year for patients with relapsed and refractory follicular lymphoma who have seen at least 2 prior lines of therapy. So this is just a cartoon that I think most of you are very aware of, but just to review the whole process for CAR T cell therapy. So initially, patients undergo leukapheresis, and that leukapheresis product is then shipped to the company that's going to make the CAR T cells, and they isolate the T cells from the leukapheresis product and then engineer those to express the modified T cell receptor that's targeting CD19, which is present on the surface of all B cell lymphomas. And it takes about 3 to 4 weeks for that process before they're returned to the site. And then once they're returned to the site, the patient receives what's called preconditioning chemotherapy, which usually is outpatient chemotherapy, 3 days of fludarabine and Cytoxan. And then there's a couple of days for the chemotherapy to wash out. And at least at our site, the patients are then admitted for infusion of their CAR T cells. I know there are some centers that are now doing this as an outpatient. we have a minimum 7-day inpatient stay for these patients after CAR T cell therapy. And I think our median stay is about 10 days. So just in terms of the logistics of the CAR T cell therapy, again, the patients to be eligible with the current FDA approval have to have seen at least 2 prior lines of therapy, and patients who have active infection, inflammatory disorders, some autoimmune disorders are not eligible for this approach. And the patients do need to be referred to specialized centers that are familiar with this procedure for their lymphodepleting chemotherapy as well as their CAR T cell therapy, because we need to watch carefully for neurotoxicity and CRS in these patients. And then after the procedure, I think in addition to monitoring for relapse and recurrence, if the patients are referred back to their primary oncologist, that we do need to be aware that these patients can have very delayed cytopenias up to several months, even a year after the treatment. So they need to have their counts checked frequently, and most of these patients do stay on PGP prophylaxis as well as antivirals and have IgG levels checked, and some of them need to be on IVIG as well. So I'm going to start with the ZUMA5 study, which was the study that resulted in FDA approval of CAR T cell therapy for relapsed and refractory follicular lymphoma. And this study included both follicular and marginal zone patients, but I'm just going to limit my remarks to the follicular lymphoma cohort. So again, had to have had at least 2 prior lines of therapy. This study did include the fludarabine and Cytoxan as the conditioning regimen. And the primary endpoint was overall response rate, with secondary endpoints being CR and PFS and OS, as well as the AE profile. So the response rates look very encouraging. So there in the middle are the cohort who had follicular lymphoma, and the overall response rate was 94% with 80% CR rate, and which is obviously very encouraging. And I think what we're all most interested in is the durability, which is shown on this slide. So on the left is the duration of response, and the blue curve is the follicular lymphoma patients. So you can see that still continuing to see some drop-offs out there in the 18-month range. And on the right, I think, is what we've seen with many therapies for follicular lymphoma, is that the solid blue curve are the patients who achieved a complete remission, compared to the dotted blue curve, which are the patients that achieved a partial remission. So patients who have partial remission as their best response generally have a fairly rapid time to relapse, as opposed to the CR patients. And then this shows the PFS curves. And again, this was data that was presented last year at ASH by Dr. Jacobson. And on the left is the PFS, and on the right is the overall survival curve. And then this data is going to be updated by Dr. Neelapu at this meeting. And so the ASH 2021 update is that at a median follow-up of 30 months, that the median PFS is now 39.6 months, with a 24-month overall survival of 81%. So a median PFS of just over 3 years, which is very encouraging. And I think it's still a little early. I think we need, as we do with all the follicular lymphoma studies, need even longer follow-up, but certainly compared to the other drugs we've heard about today that have the median PFS, around the 1-year mark, having that median PFS be around the 3-year mark is obviously very encouraging. And then also at this meeting, and I think actually Dr. Jacobson presented this at last year's ASH, was looking at the subsets of follicular lymphoma patients treated on the ZUMA5 trial, specifically those patients who had an early relapse within 24 months of initiating their first line of therapy, compared to those patients who had longer remissions. And as you can see, that the overall response rates were outstanding in both of those groups, as were the CR rates, 78% and 90% respectively. And then Dr. Jacobson presented the 18-month duration of response, the 18-month PFS and overall survival, which, if you compare the middle column to the right-hand column, looks like it's probably a bit better in the patients who had longer initial remissions, but still very respectable data. even in the patients who had rapid relapse after their first line of therapy. In terms of the safety data for ZUMA5, I would say overall that all of us have the sense that it's a little bit less toxic in patients with follicular lymphoma than we saw with the CAR T experience in diffuse large B-cell lymphoma. Still a high rate of CRS. In this study, about 78% of patients had CRS, but primarily grade 1 with some grade 2. Very low incidence of grade 3 or higher CRS, 6% in this study. And most of the CRS was fever and hypotension. In terms of neurologic events, again, looks more favorable than we saw with this particular agent in DLBCL, where the incidence of grade 3 or greater neurotoxicity was more in the 30% range. So in the follicular lymphoma study, about 15% of the patients had grade 3 or higher neuro events, which is still of concern and something we need to continue to work on. Most of the neuro events were tremor and confusion. And then I put in the box there on the right that I just want to remind people that prolonged cytopenias are also something we see with CAR T-cell therapy in follicular lymphoma as well as in DLBCL. So in the ZUMA5 study, about a third of the patients with follicular lymphoma still had grade 3 or higher cytopenias more than 30 days after the infusion. So then I'm also going to speak briefly about the Elara study, which is the study with Tisacel, and they had 94 patients who had relapsed and refractory follicular lymphoma treated with this agent. And the overall response rate, again, very high at 86% with a CR rate of 66%. So hard to compare across studies, but again, looks very encouraging, maybe a slightly smaller CR rate, lower CR rate than we saw with the Axicell. And then the median duration of remission at the time of this presentation, which was in ASCO this year, had still not been reached with 11-month follow-up. And I wanted to point out that something that's a little bit different than my experience with DLBCL patients in CAR T is that third bullet in the box where 12 of 31 of the patients who achieved a partial remission converted to a complete remission. And all of those conversions, except one, occurred between month 3 and month 6. So I think we all worry we worry a lot about our DLBCL patients after CAR T-cell therapy who still only have a PR at month 3. But with these patients, you should probably hang in there and not give additional therapy as long as they're not symptomatic, because there is about a 30% chance that that patient will then go on to achieve a CR. And then this shows the median PFS and overall survival curves for the Aliris study. And we're going to see an interesting update at this meeting, that the median follow-up of the abstract that's going to be presented by Dr. Thiel-Beaumont at this meeting is 17-month follow-up with a 12-month PFS of 67%. So that's in contrast to the previous presentation, which had a 6-month PFS of 76%. So still seeing some drop-off between the 6-month and the 12-month time point. And then they're going to show us the 12-month PFS for patients who had POD24, and you can see that's a little bit small, a little bit shorter than patients who had a longer initial remission. So 61% were still in remission at 12 months versus 78%. And then patients who had bulky disease, so the high total metabolic tumor volume, 54% versus patients who had less bulky disease, where the 12-month PFS is 68%. And then they also looked at the number of prior lines of therapy, which I think we're all interested in terms of when we need to jump in with this and still have the treatment work. So I was very encouraged to see that even patients who had had at least 5 prior lines of therapy had a 12-month PFS on this study of 60%, compared to about 70% for the patients who had had fewer numbers of therapies. In terms of the safety, looks very good. In fact, looks a little bit better than the ZUMA5 data. And that's true in the DLBCL cohorts with the Tisacel as well. So about half of patients had CRS, but there were no reports of grade 3 or higher CRS, and only 1% of patients had grade 3 or higher neurotoxicity. And they did mention that most of the CRS and ICANS events were in patients who had bulky disease. So probably want to keep that in mind in terms of monitoring these patients. So then I want to switch to talk for a few minutes about the bispecific antibodies, which are in development for relapse and refractory follicular lymphoma. And all of these ones that are currently being looked at are CD20, CD3 bispecifics, and I'll show a cartoon on the next slide. But these are the four: mosunetuzumab, epcoritamab, odronextamab, and glofitamab that we have some preliminary data to look at. And of note, the mosunetuzumab has been given FDA breakthrough designation for relapsed and refractory follicular lymphoma. So just the general schema for the mechanism for these T-cell dependent bispecific antibodies. So there on the left, you can see that the IgG antibody targets both CD20 on the B cell as well as CD3 on the T cell. And then the cartoon shows what happens after these two cells are engaged with the antibody, so the T cell and the target lymphoma cell, that causes T cell activation and release of granzyme and perforin, and hopefully death of the lymphoma cell. But the T cell activation also results in cytokine release, which is where we see some of the side effects. So I'm going to start with mosunetuzumab, which is going to be presented at this meeting by Dr. Buddy, and hopefully will show up online in the next few weeks in JCO as well. And very encouraging data. So these patients had to have at least 2 prior lines of therapy, so similar to the CAR T cell patients, and had to have grades 1 to 3A. So these studies do not include patients with 3B. And these patients also had to have a good performance status similar to the CAR T cell studies. So the overall response in the 90 patients that are going to be presented at this meeting was 79% with a CR rate of 58%. And then you can see the data in the right-hand column there for patients who are higher risk. So the POD24 patients had a CR rate of 55%. Interestingly, the best CR rates were seen in the patients who had had only 2 prior lines of therapy, but still very high, 52% in patients who had had 3 or more prior lines of therapy, and CR rates that are comparable in patients who were refractory to prior CD20 and refractory to alkylators. And then this is the data that's also going to be presented at this meeting by Dr. Morshauser. And this is for glofitamab. And they had 2 cohorts in their study. So one that was monotherapy and one that included a combination with obinutuzumab. And overall response rate was 81% with a complete metabolic response rate of 70% in the mono cohort. And I've highlighted the mono cohort results there because there was increased toxicity in the obinutuzumab glofitamab combination. So I'm not sure what the company is planning, but I'm guessing proceeding with this as monotherapy. And you can see again, they've shown you the complete remission rates for the highest risk patients. So for instance, the POD24 patients here had a CR rate of 58%, so similar to what we saw with Mosun. And the last line there shows patients who had very bulky disease still had a CR rate of 63%. And then the last bispecific I'm going to speak about briefly is the epcoritamab. And this data was actually published this year in Lancet. And this was a phase 1 study that included patients with several subtypes, both aggressive and low-grade NHL. And they specifically call out in the manuscript the 11 patients who had follicular lymphoma. So very small numbers, but interestingly, the overall response rates, 81% in these 11 patients with a CR rate of 45%. So again, looking very similar to the GlowFit and the Mosun, which we just looked at. And this is an interesting molecule because this was the first company to explore subcutaneous administration of the bispecific. Mosun is also now in tests or in studies in the subQ formulation as well, but some evidence that this decreases the risk of CRS and also just a better PK profile for these patients. I'm not sure it's going to, I think what we need to figure out is whether there's any difference in the response rates when it's given IV versus sub-Q. So just to sort of summarize the safety experience with the bispecifics and maybe contrast it a little bit to the CAR T cell therapy, that the CRS is fairly prominent. In these 3 studies that I've just shown, the incidence was anywhere from 45 to 79%, but almost exclusively grade 1. A small percentage of patients have grade 2, and the incidence of grade 3 in these 3 studies was 0 to 2%. And no fatalities related to CRS on any of these studies. And there are some potential mitigation strategies, which all of the companies are looking at. One of which is the cycle 1 step-up dosing, where patients get a very small dose of the bispecific on cycle 1, day 1, slightly higher dose on cycle 1, day 8, and then full dose on cycle 1, day 15, or on cycle 2, day 1. And then the subcutaneous administration also looks like an effective mitigation strategy for CRS. And in all 3 of these studies, the use of tocilizumab and steroids was very uncommon. Then the neurotoxicity, although overall neurotoxicity was reported in 5 to 35% of patients, almost all of these were grade 1 with a smattering of grade 2. The incidence of grade 3 neurotoxicity is extremely rare. In these 3 studies, it was 1% or less. And the most common neurotoxicity is headache, which I think is usually treatable and less concerning than some of the neurotoxicities that can be seen with the CAR T cells, where we've seen reports of things like aphasia, seizures, encephalopathy, cerebral edema. I don't think there's any reports of those kind of neurotoxicities. And then the cytopenias, although about a quarter of the patients in these studies do develop grade 3 or higher neutropenia, the incidence of febrile neutropenia and serious infections is extremely low, much lower than reported with CAR T cell therapy. So my take homes for the immunotherapy and follicular lymphoma, I think both the CAR T cells and bispecific antibodies are highly effective therapies. And of course, we need longer follow-up because it's follicular lymphoma. But the patients who achieve a CR with either of these therapies appear to have some durability, at least over the first few years. I think it's too early to use the word cure, although we're quite hopeful that either one or both of these therapies will hopefully result in prolonged remissions. And then I think the bispecific antibodies have the advantage over CAR T of being off the shelf, so patients can start treatment very quickly, outpatient administration, certainly a pretty favorable toxicity profile. And I anticipate that we will have FDA approval of at least one of the bispecifics in 2022, perhaps early 2023, but I'm hopeful 2022. And then I still have questions in my mind about how to sequence these. And I think it might be a different sequence for follicular lymphoma than it would be for DLBCL. But I guess in follicular lymphoma, I'd probably lean toward bispecifics once those are approved, or even on a clinical trial at this point before heading to the CAR Ts. And I think we don't know yet, but I think it was certainly under investigation about whether either of these treatments should be moved up in the lines of therapy for follicular lymphoma. So just to bounce back to the case again, with this patient who had a relatively rapid relapse after BR and then another rapid relapse after R squared, that I do think immunotherapy is a reasonable treatment choice. I think we've already kind of touched on this in terms of how the bulk of disease and how symptomatic the patient is in terms of what you might do next, but just kind of my thoughts, and then I'll turn it over to my colleagues in terms of considerations that I think if you have a clinical trial available for bispecifics, and hopefully later this year even, or later next year, maybe even FDA approval, that, as I've already mentioned, I think the bispecifics probably have a more favorable safety profile, the fact that the patients can start treatment immediately, and this outpatient administration is an advantage. I think the CAR T cells are very effective, and I generally delay choosing those until 4th line or perhaps even later, just because, as we've talked about, all these other great options that have very minimal toxicity. And even if you can by a few years before the patient has to undergo this therapy. That's a good thing in my mind. And I still have some delay, some concern, not only about the acute toxicities of CAR T-cell therapy, but also these delayed cytopenias and infections. And if the patient did relapse within that first year, then I think it's a little bit harder after CAR T-cell therapy to jump in with the next line of therapy because of issues with infection. But very interested in what Nathan and Krish have to say in terms of how they might approach these patients in terms of sequencing these immunotherapies.
Thanks, Nancy. Um, it's one of these like good bad problems to have. We have I know all of us have been practicing since the days where these patients, it was transplant or just something that was palliative. So at least in my it's I think it's one of these, I hate to use this word, but it's one of these kind of art of medicine type eras where, at least in my own practice, it's understanding kind of the disease process. So one of the things I always get concerned about is, when we think about these just in line of therapy, which is where they're all approved, in third line or second line, because in follicular, where and I know you guys obviously know all this, is that you can have a patient that is in the third line, but it took 2.5 years to get there, or the patient's in the third line, it took 15 years to get there. That's a very different patient. And, at least when I'm thinking about CAR T or BiTEs, I tend to, as you pointed out, you think about those as options for patients that are feeling a fairly rapid order, which is this patient here, versus, I probably, even though the adverse event rate is lower than large cell, it's still concerning in a little population. At least today, I don't know who those patients are. So in a patient that, and as we've seen the survival of follicular lymphoma now in most patients is going to mirror the population without lymphoma. So what I definitely don't want to do is give a patient something that could lead to some permanent, potentially disabling side effect, and the patient would never have died of lymphoma. And for me, I don't know. I think that unfortunately we don't have biomarkers. We talked about POD24 and some other things, but for me, it's kind of a gestalt. I look at how aggressive the disease is and what other options I have, and I make an educated decision with the patient around risk benefit. So that's, again, not a great answer, except that I tend to don't look as much into the third line as I do is kind of the kinetics of each line of treatment when I'm deciding which of these three options to choose. Krish, I don't know.
Yeah, I mean, I would certainly agree with a lot that you both mentioned, which is the tempo of disease and the biology of the disease in that individual patient really kind of drives this conversation. I think the off-the-shelf nature of the bispecific antibodies is really, I think, a big advantage, as Nancy pointed out, especially some of those patients who, they have follicular lymphoma, but as you pointed out, Nation, the time between treatments is very short, and perhaps you even have a concern about occult transformation. These are agents that are active in DLBCL, as Nancy pointed out. So that's a patient where if I'm worried about that, that may push me towards an immunotherapy. And Nancy's comment about, the downstream of the CAR T, I think is particularly important. When we think about bispecific antibodies, we're really relying on the native T cell health. And, one of the things that certainly we don't know a lot about is what is that post-CAR T cell therapy. So while bispecifics can be active in that setting, post-CAR T cell therapy, sequencing these agents is going to be really important. So, where are we getting the maximum output from these therapies, and what are the upstream therapies impact is something I try to think about. And of course, now we're also moving in an era of allogeneic cellular therapies, so off-the-shelf manufactured therapies. So I think you put it really well, both of you, that, these really need to be individualized. The one thing I've also noted is, and this is a bit different in follicular lymphoma than large cell, is sometimes my patients have said, I really like the one-time nature of CAR T-cell therapy. So I totally get that it may be a more toxic therapy, but I'm looking at it as a one and done and potentially not having to be on a therapy indefinitely. So this concept of a fixed duration of treatment may be appealing to some patients as well.
That's a great point, Krish. And I guess I did forget to point out that with the GlowFit and the Mosin study, that it is a fixed duration, much longer than the CAR T cell therapy, obviously. But patients who achieve a CR are they stop after 8 cycles, and the cycles are every 3 weeks. So that's about 6 months of therapy. And patients who have a PR were allowed on these studies to go on, at least on the Mosin study, to a total of 17 cycles. So it's not one of those treatments like the PI3K and the Tasmetostat that we talked about, where patients stay on them until progression, that if they do have a CR. So a lot of these results are patients who have been off therapy for quite some time, which again looks encouraging.
What do so? And how about Nance or Krish? As you mentioned, the target is CD20 for the bites versus 19 for the CAR T. Does this make a difference to you? In other words, if a patient's had multiple CD20s, would you pick a 19 before, or again, does that enter in? Assuming all these drugs are FDA approved in the future, would you pick a 19 before, or vice versa?
So that's a great question. And I'm hoping that we see more data um, that especially from the Mosin and the GlowFit studies, which are the ones that I've been involved with, in terms of looking at the, like, say, CD20 density that they can measure in a patient who's failed all these other CD20 therapies. But what we do know is that these anti-CD20 bispecific antibodies are very effective in patients who have failed prior anti-CD20 therapy, excuse me, and including as their most recent line of treatment. So we do need more information about that for sure.
And I'll throw an oddball question. How about combinations? Do you see any of these, like for example, PI3 or CH2 or others being combined with CAR T or bites? Well, you mentioned a little bit about the CD20, but
Yeah, it's interesting, right? So, especially with bispecific antibodies, other immunomodulatory drugs may augment the sort of T cell activity, right? So you think about lenalidomide or even PI3 kinase inhibitors. So those might be perhaps rational partners. Of course, the downside of that is, what does that do to toxicity? I think maybe borrowing a little bit from CLL, combining BTK inhibitors with CAR T cells seems to maybe ameliorate some of the cytokine release and toxicity. So I think it's a really interesting time, Nathan, and hopefully the science will lead us to these rational combinations, or even combinations of bispecifics with CAR T cells, right? They're CD3 engaging therapies, so you may be able to get dual antigen targeting from a bispecific and a CD19 CAR T cell. So
Those are great points, and I would just point out that at this meeting there is a presentation of the preliminary results of the mosunetuzumab plus lenalidomide for relapsed and refractory follicular lymphoma, and then the phase 3 study, which I'm not sure if either one of your sites is participating in, just opened, and that's actually in the second line or greater. So patients who had to have relapsed only after one prior therapy, comparing mosun plus len to R-len. So I think that'll be interesting to see. Again, can we move up one line or not? Is it helpful or not? Yeah.
is there a population that you would assume? Let's say we do get these or the studies read out positive. Is there we talked a little about POD24, but is there any other indication we might move to second line, or goodness, even earlier with CAR T or BiTE?
Yeah, I don't know. I think I'm really glad that they're jumping in with a phase 3 study in the second line setting, so that we can actually make some educated decisions about whether that's the right place for it. And I think mosunetuzumab len versus R-len is a great comparator in terms of whether there is an advantage in that line. And I don't know about the CAR Ts, earlier than third line. I mean, I guess we're going to see lots of data at this meeting for the DLBCL cohort in patients who are primary refractory. But I think the patients who have primary refractory follicular lymphoma are few and far between, and they're probably patients who have some DLBCL. And so, I think they're going to have to be very careful about choosing patients for CAR T as earlier line of therapy.
My my former colleague Fernando Cabanillas used to say that there's this group of folliculars that even though you biopsy, they never show large cell, but they behave like large cell. And I'm just thinking out loud that maybe the population is someone that that they would benefit from an earlier line or earlier intervention, right?
Yeah. Thankfully, those patients are pretty rare. Even I don't know what you guys think. I mean, we have a hard time finding any POD24 patients for trials. That thankfully that's an uncommon subset as well.
So thanks. That's exciting time with lots of good options. So at the meeting, I know we talked about several of these. I just kind of picked the five abstracts that I think are really exciting and potentially practice changing. And we talked about several of these already. Catherine Thibaumont will present the Elara data, and this will actually come out in Nature Medicine about a week after ASH. We'll also see some updated data on glofitamab plus Obin, as Nancy mentioned, mosunetuzumab. My colleague Safanilopoulos is going to present a longer-term update on ZUMA5, which is the axicell and follicular. And finally, we'll also see an update on the Unity NHL trial, but this one is now looking at the U2 regimen, which is umbralisib plus monoclonal antibody ublituximab in marginal zone lymphoma. And to remind folks, umbralisumab was approved as a single agent for marginal zone lymphoma in that disease. So we already got some questions from the audience, and just in the interest of time, I'm going to just pick a couple of these. And I think, Chris, you kind of went to this. I'm going to ask you this question because you mentioned this a little bit earlier about EZH2 testing. And you mentioned that again, in Seattle, you guys are doing this as baseline. Should we be checking EZH2 in everybody with follicular?
Yeah, I think it's still an open question. We certainly do it primarily because we think it helps us to identify, or interpret, I should say, response rates. We mentioned the kind of difference in what was seen, at least of radiographic responses. But I think one could certainly also make the argument that if it doesn't impact our selection of therapy, that we could use an EZH2 inhibitor in any patient with follicular lymphoma, then perhaps we don't need to do it. So I think it'll be interesting to see if there continues to be a difference in responses when we are studying EZH2 inhibitors in combinations. And so, I think we'll see with more data.
And again, you mentioned about, although it's active in wild type, are you more likely to sequence it earlier if patients have EZH2 positive disease?
Yeah, I think coming back to a point you made earlier, Nathan, which is, if you have a patient with bulky disease and, let's say that disease is, you want to get that knocked down, or you feel that you need maybe a little bit more confidence that you're going to get a tumor reduction, then I think having the mutation status is helpful. We saw that 98% of the patients that have mutated EZH2 had a reduction in tumor volume compared to about, 60% in the wild type. So there it might be helpful in selection. And so that's certainly supported by the label as well.
Yeah, that's good. I'll take this one here about there's a couple on PI3 kinase inhibitors. Specifically around re-challenge patients after prior exposure. I think it all depends on why they're off. So if they had let's say severe pneumonitis, I probably would not re-challenge with another drug in that same class. Colitis or diarrhea, again, I think that depends on really the severity of the event. If they had a grade 2 event and they came off drug and potentially, I didn't have other options, I definitely would consider restarting. In patients who progress, in my mind, I don't know enough if there's enough evidence that they're significantly different, that I would necessarily, if they had a frank progression on one drug in this class, I probably would go to a different class of drugs. I probably would not repeat another PI3. I don't know if Nancy or Chris, you agree with that?
Oh, I agree, but I was just thinking what I might do. So now if sandilisib gets approved with those higher response rates, that it seems like maybe there would be an advantage to that drug. So in a patient who's already failed a sort of an older PI3K, what do you guys think? Maybe I would be willing to try that just because the data looks different than it does for the other
Yeah.
4 drugs.
Yeah.
Otherwise, I agree with you. I wouldn't. We have so many choices. I would just say that there wouldn't be a reason to re-challenge a patient.
Krish, what do you think?
Yeah, I think similarly so. We don't necessarily understand mechanisms of resistance in PI3 kinase inhibitors all that well. So that makes it a little challenging to consider re-challenge. And as you both said, there are so many other therapies we have, as well as other trials that patients might benefit from.
Yes. I agree. And this question here, there's a question about how do patients tolerate next generation PI3s compared to Idela? I mean, my own sense is better, whether that's due to, better drugs or because we're just, we're getting better at managing the side effects and educating patients about when to stop. I think that's, my sense is that the drugs are different, that they are less toxic, but, yeah, I think that they do tolerate them better, but probably for a combination of reasons. What do you guys think about moving either EZH2 or PI3 kinase earlier? Is there a population you would use this, for example, in frontline? Nancy, what do you think?
Well, I'm not sure. I think the PI3Ks, I think with the adverse event profile that I probably wouldn't be that anxious to move that up, but the tazemetostat, because it's so well tolerated, and again, I don't know whether there's any in laboratory evidence that it is synergistic with other drugs, but it certainly seems like that's an easy drug to move up and mix. So I don't know if those studies are already going on, but that seems like something we should probably be exploring.
Yeah, I don't know if there's any frontline. I'm not aware of any frontline with PI3 for sure. Not that Krish, I don't think, have you heard of anything in the frontline study wise?
No, I'm not aware of any either.
Yeah. Well, how about, moving away from frontline, what about using, for example, EZH2 as a bridge to CAR T or PI3? Is there any role there? If let's say you're assuming you're going to get a patient a CAR T and you're looking for something to hold the line for a little while, would you use one of these drugs?
Yeah, I think those could be interesting uses of either of those drugs. I think perhaps different than large cell lymphoma and follicular lymphoma, we don't tend to see as much use of bridging because the kinetics of the disease are different. So sometimes we may not need to bridge, but I think if we do, or patients are certainly symptomatic from their disease, and it still takes time to get an autologous CAR T cell delivered, then these may be good agents to use. Or I've even had a patient, actually, as an example, where we apheresed the patient, we manufactured the commercial CAR T cell, and that patient did need some bridging, and we put that patient on duvelisib, and the patient stayed on the duvelisib, and we have the CAR T cells kind of banked now for a rainy day, if you will. But
yeah, that's good and good. That's a great example. So again, I will. Let me just quickly say, Nancy and Krish, thank you for a wonderful session. We were able to touch on some really exciting new drugs, a lot of the highlights that are going to be seen or have already been seen at this ASH meeting.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.